Good morning all. At the outset, let me thank Meena Madam for including me in this excellent instruction course. So I will be talking about the ERM, Epithelial Membrane Management. So a slide first to just let you know what it is. It's a fibrocellular tissue found on the inner surface of the retina, semi-translucent and proliferates on the surface of the internal limiting membrane. Now we have got two situations basically where you have the ERM. One is the idiopathic, which is the commonest where we usually feel, and the other one is the secondary ERM, secondary to so many diseases which have been mentioned here. You can see, I'm not going through the list. And when you talk about the pathology, it's basically the membrane is composed of retinal glial and retinal pigment epithelial cells. Then there will be fibrous astrocytes, fibrocytes, myofibrocytes, and macrophages also, depending upon the pathology and whether there is a secondary component also involved. The pathophysiology, as Madam was talking about, it's all related to the, especially the idiopathic, is related to the anomalous PVD. So when you have the PVD, there will be a residual cortical vitreous on the ILM due to the incomplete separation. This itself, if supported by some inflammatory material, can proliferate into an epithelial membrane. Or in addition to that, there can be some dehiscences in the ILM through which the microglial cells can migrate to the surface and results in proliferation of the glial cells over the top of the ILM. And for secondary ERM, there will be other inflammatory mediators which is also coming into the pathophysiology. Now, as far as the diagnosis, initially in the early stages it used to be difficult because in the fundospecular we may not be able to see much of that. It may not be that evident, but with the coming of the OCT, it is quite easy because it is very well distinguishable in the OCT as a discrete, irregular and hyperreflective line. Now in the OCT, I'm not going through all these things. In the OCT, one thing that I wanted to stress is the presence of, this is one thing that we'll be looking for, the presence of any continuous ectopic inner foveal layer, or EIFL. This is a band which is extending from the inner nuclear layer and inner plexiform layer across the fovea. Now, when those layers are present, it results in a poorer prognosis. And it is also important as far as the staging of the ERM is concerned, based on the OCT which you can see here. The first two stages, we don't have the EIFL or the ectopic inner foveal layers. In the second, in the third stage and the fourth stage, we have got this the EIFL, and the last one, that is stage 4, we have got the EIFL especially, and along with that there will be a complete distortion of the retinal layers. We don't be able to distinguish the retinal layers at all. Now, regarding the treatment, there is no confusion. It is pars plana vitrectomy plus the peeling of the epiretinal membrane. Now, these issues in the decision making which we are more concerned about here is that one is when to operate and when not to operate. Now, there will be what is the visual acuity threshold at which you operate, whether you operate in asymptomatic patients. So there is a lot of differences from surgeon to surgeon as far as this is concerned, but generally, especially personally speaking, I usually have a visual threshold of about 6/12. I don't operate when the vision is better than 6/12, but that can vary. And significant metamorphosia is another probable indication when we would basically decide on peeling that. The second important issue which we are more concerned here is how to manage the ILM at the time of the surgery. Whether we peel the ILM along with the ERM, that is called the double peel, whether we do it, or whether we peel only the ERM, that is a single peel. Now, the little difficult decision because the jury is still out. Now, the arguments in favor of the ILM peel or the double peel is that if you peel the ILM, it is going to ensure complete removal of the epithelial membrane, no doubt about that. It reduces the recurrence rate and it also facilitates greater resolution of the retinal folds and better anatomical restoration. But it is not a procedure, as ma'am has already told. It has got some risk because there can be the stripping of the ILM remove the Muller cell foot plates. So it is reasonable to expect some amount of retinal trauma. And there will be other adverse events, sometimes such as the eccentric paracentral macular hole formation, the macular microscotoma, the retinal dimpling, and these are some of these things. So in the presence of this, may not be very visually relevant, in the presence of this, is the ILM peel going to give you some additional advantage as far as the vision is concerned? Now, all the studies have failed to actually conclude that there is a significant difference as far as the long-term visual outcome is concerned, whether you peel the ILM or not. And many of these recurrences, for example, if you look at this study, this wonderful study actually outlines all these studies in 2003, 2017, and there is no significant difference as far as the visual acuity is concerned in all these studies between the double peel and the single peel. And also the recurrences, many of these recurrences are not significant. Large part of these recurrences are not significant enough to produce a visual indication, again visual deterioration so much as to indicate a reoperation. So another aspect is the simultaneous, sometimes some of the ILM also peels along with the ERM whether you want it or not. So that is also there. And Tranos et al. Has actually proposed a method, based upon their study. They have even proposed that if you are peeling the ILM, then it may be limited to patients showing focal, that is less than 50% of ERM macular adhesions on the preoperative SD-OCT, so as to avoid unnecessary trauma to the retina. So the basic the procedure which I am generally doing is that initially I complete the vitrectomy, cord vitrectomy, then use the triamcinolone in order to check for the PVD, make sure that the PVD is complete. If the PVD is not complete, induce the PVD, then stain the ILM with brilliant blue-green under air, and after staining I generally start an ILM peel from an area where there is no ERM, that is much beyond the ERM, so that this is an area where there is no ERM, and once it reaches up to the edge of the ERM, I can even see that ERM being lifted by the ILM, because the ILM is anyway under the ERM. So at this point you can definitely see the edge of the ERM, and once that ILM reaches up to the edge where the ERM is there, now I will just shift the instrument, but till now I was using the membrane scraper. Now I take the ILM forceps and try to grasp both the ILM and the epiretinal membrane in a single hold and try to strip the entire thing. So now what I think is that I am removing the ERM along with that ILM what is coming off. I may not be always correct, so some of the ILM may be still left there, but I think I am getting most of the ILM. And after this, this will be followed by the fluid air exchange, and it will be left with air. So this was that case. This is the preoperative, you can see the preoperative OCT, and this is the postoperative picture after 2 months. So there is a definite improvement here. The vision has improved so much. In another case, again the same this thing, starting the ILM peel from an area much beyond, and now when you are coming to that area, grasping the ERM here, but in this case, as you can see, the ILM fragments, I am not very sure whether I got everything out there, probably some of the ILM is left there, but it's a very thick ERM, and so it is coming out as a whole, as you can see in the video. So that is the ERM coming off, and then it is followed by the fluid air exchange, and you leave it like that. Now, so this was that case. So that is the preoperative OCT and the postoperative OCT, you can see. Now, some of these cases, especially this was a secondary ERM. I'm not very, don't remember exactly what it was, because it was done a long time back. But here, as you can see, even the PVD, I was not able to complete. There is the PVD is also a very thick and posterior hyaloid. You can see the triamcinolone crystals still remaining there. So I had to actually incise the posterior hyaloid with a membrane pick. And after incising the membrane pick, I am trying to get the hyaloid, peel the hyaloid also. That is another membrane. Now, in this area you can see that the hyaloid is actually attached to the ERM, and along with that hyaloid, the ERM also is coming off. So in this case, here you can see that the ERM is also coming off along with that hyaloid. So such cases, you again stain with brilliant blue-green after finishing off the, after removing the whatever posterior vitreous is remaining. Then I stain again. So this is exactly what is that you come again and stain with brilliant blue-green, and again start the ILM peeling. So I'm grasping with the forceps here. You can see the ILM peeling is being completed. So this case, actually it also So it's almost complete. So that is the ILM being taken off. And yeah, that membrane just finishing. And here also you can see some. I mean, this is all mild trauma. This can what was mentioned. Sometimes this happens when you are trying to grasp the ILM. So I had to laser that area, even though it was a full thickness wall. Maybe it was not necessary, but that was done. So again, coming to the conclusion, so peeling of the ILM definitely ensures complete removal of the ERM. It improves the prognosis and reduces the risk of the ERM recurrence. But the fact is that current literature has failed to provide a strong evidence for the beneficial role of the ILM removal during the ERM surgery. And so it is up to the individual surgeon, and it varies from case to case also. Thank you.
Thank you, Biju, for those excellent videos. If there are no questions from the audience, how many of you practice retina? I saw Thomas Cherian. 3, 4 of us. So do you do a combined ERM ILM peel, or you peel only the ILM? Only the or the ERM. Okay.